Afternoon and welcome to beginning chest radiograph interpretation. My name is Greg Brooks. I'm a family nurse practitioner and I reside right now in the state of Arkansas, close to Little Rock. If those of you know where Little Rock is at, I grew up in Oklahoma, so I don't know which one will get me more accolades or more booze, but Okie and from Arkansas. So New Mexico is beautiful, and so I am honored to be invited out here to speak a little bit on this. So I got into X-rays by virtue of playing sports. I broke more bones and more, fractured fingers, fractured arms, forearms, spent times in casts, and so I just by virtue of my broken boneness, I got interested in radiographs, and then after I graduated, I worked in emergency rooms and urgent cares this was back in 2000 when F&Ps were assisting in those areas. So I got experience in reading radiographs, and it's something that I enjoy teaching and sharing knowledge. And again, this is normally about an hour and 15-minute lecture discussion, so I'm going to try and bring it into 45 minutes. So if I fail to include something or address something, you are free to contact me at gbrooks@harding.edu. I teach at Harding University. I'm glad to impart knowledge, instruction, and little pearls that I've learned along the way. Let's see if we can get going here. Works there. Oh. Okay, we'll move a little closer. And it's still giving me fits here. So just to kind of, now it's not advancing like it was before, so. Okay, so basically just today's workshop, we'll be able to review we'll try and get an organized approach and how do we look at x-rays, how do we just kind of get a baseline approach to it, and then we'll try to learn how to differentiate normal from abnormals. Those of you who know me from my previous sessions know that the only dumb question is the one that's never asked. So please don't hesitate to ask a question. Sometimes I may say, okay, great question, give me about 2 or 3 more slides, and I'll try to advance it that way. So some radiographic terms, I won't go into all of these for time's sakes, but I will say that, again, this is what we're going to be looking at today. And even today, back in the time when I was getting x-rays, it was the get a film, wait 15 minutes for it to develop. Nowadays, it's almost computerized. You get an instantaneous type of recording with that. There's ultrasound and CT and MRIs, which I won't be going into in this presentation, but we will talk about some of the other components here and talk about beam direction and the body parts that are closest to the film. These are things that you're going to be considering when you look at chest x-rays. There's basic densities that we're going to be looking at here, and I'll use this example right here. Gas is going to be all dark. So you can look right here on the sides of this person right here. This is the absence of any type of tissue, the absence of any type of tissue that may be present or occluding any of the x-ray beams that appears. Now in the lungs, you can kind of see there's a lot of air in the lungs. That makes sense, duh. So it's going to appear darker here in the lungs than it will be in other areas. Now you look at some of these others, why do they appear as the way they do? Well, you can see right here fats and lipids that appear right here on the sides, very sides of this young lady are going to appear a little darker. And you can see if you've got a whole lot of tissue, a lot of fat that may be present, as in the breast tissues right here, you can kind of see as it overlaps, the denser it's going to be. Going to be an important pearl as we continue on. Now, soft tissue like muscles will appear a little bit darker. You can kind of see as we get more organs over, it's just going to appear a little bit darker, a little bit, or I say darker, it's going to be appear a little bit whiter. And then calcium and bone, you can see right here, are going to appear almost as tunnels. Now, why do they appear as tunnels? Well, sometimes they'll appear as tunnels just because you've got overlapping calcium on the tops and the bottoms versus a tube type of an appearance that you'll see as it comes towards you. But you can kind of see right through here, that's going to be probably your more dense piece until you get to a foreign body, such as that marker right up there at the top. A foreign body or a metal is going to appear almost solid. So the different types of tissues kind of give a clue in terms of what's going on. So if I have Lots of air in the lungs, it's going to appear darker. If I have more soft tissue or fats or lipids or some type of growth, it's going to appear a little bit more solid. And if I've got some type of infection process that's going on, it'll appear a little bit more lighter as well. Now, let me kind of give a word on x-rays. Too many times we go into a place and the standard is order an x-ray, make your diagnosis off that. Well, the standard spiel that I've got to tell you is make sure you have a rationale as to why you're doing a chest x-ray. A chest x-ray should either support a diagnosis that you think is going on, or it should refute a diagnosis. Before you get that x-ray, you should have an idea that, I think there may be a pneumonia in this particular area. If it's going to change how you treat or if it's going to change how you approach or you need to document, go ahead and get that x-ray. But if you already know this person's got an x-ray, you may not need to get the x-ray. If you already know what's going on, you've got a good history. And I say that because I work in areas where they're underserved, don't have as many resources, and getting an x-ray is going to be more expenses on them. So really have a good rationale as to why you are ordering that x-ray. It should not replace a good history or physical examination. I tell people all the time, make sure you get a good history. Don't let this, just get an x-ray and that will be the end. I had people who've misdiagnosed or overlooked things because they relied solely on the x-ray for their physical examination, and that got them in trouble. You are responsible for the entire x-ray when you get an x-ray. I say that because I had someone last time who ordered an x-ray such as this right here. This is when they had the view box, and he was looking for some type of pneumonia right here. And as he put that x-ray up in the view box, it covered up right here. Well, this kid was having a hard time breathing, having a hard time choking, and he was looking for a pneumonia, no pneumonia, pulled it off and sent the kid home. Kid died overnight because up in here was a thumbtack that the kid swallowed. So when you get an x-ray, know that you are responsible for the entire x-ray. That's why I say have a reason or a rationale as to why you're getting that x-ray. Okay, rules that I teach x-rays and I teach radiology, I teach health assessment, advanced health assessment to nurse practitioners and nurses. But we want to take more of a superior to an inferior approach. We want to work our way top to bottom, and we always want to compare side to side on one side compared to the other side because it's going to be a good mirror image for the most part. We're going to learn to work external to internal, and if I can get nothing else into you today, is learn to seek pathology. Don't assume normal. If you assume normal, you will not question anything. If you assume pathology, you are more likely to investigate, dig, and determine, is that little bitty patch that I see, could that be the problem? Versus if you assume it's normal, you dismiss it, okay? So my pearl for you today is always seek and assume pathology. Assume something's wrong until you can absolutely rule out that there's nothing there, then you're safe and you've interpreted. So when I say reading a chest x-ray, it's kind of like looking through and seeing all the structures. So when you look at all the structures of a chest x-ray, you've got to have an organized approach, and you got to be able to look at it in a way that you understand the anatomy, what's normal, what's abnormal in those particular areas. So you got to have a good working understanding of anatomy. When we talk about a right or left, you're referring to the patient's right or the patient's left. Those are things that you, as we approach it, you want to make sure that you refer to the appropriate side, especially when you're giving a report or conferring information. Okay, general approach to x-rays. Again, make sure that you always check for the patient's name. That's the easiest way to miss a malpractice suit, is to make sure you're interpreting the right patient, okay? So always check to make sure the patient's name is correct. Also look at the date it was done. Well, duh, Greg, I know what date it's done. It's the day that I ordered it. Well, in today's radiology and the way that we can store x-rays and pull up x-rays, you want to make sure that you're looking at the most current x-ray, because a lot of times you can compare it to the times in the past. And again, you might get your days mixed up. So make sure you're making it on the appropriate day, person and the appropriate time. Note if if they're upright or they're laying down or they may be on their left or on their right, that will also determine what type of pathology that you see. Okay, look at your type of film, the position, and make sure it's a good quality film. So first approach we're going to take, by the way, I got a lot of party games in this one, so this is an interactive, I promise, one on this one. So hopefully we'll have a little fun as well. First question we always want to ask is the patient, we want to evaluate the film, is the patient midline? Is the film developed correctly? And is it a good quality film? So first thing that we look at is this one, think, wow, is this a good quality film? There's several things that we're going to be looking at in this particular one. We want to, okay, I'm just going to go to this one. Is this a good adequate film? When you look at this right here, you should see that, yeah, you can see patient's midline. You can kind of see the clavicles are lined up. But boy, looking right through here, looks kind of worn through a little bit. You can't really see much of the vertebrae. We'll come back to this, but it looks a little cloudy over here. And I will tell you that there's a little difference in what you see, what I see on here versus what's being seen up there. I should be able to see the vertebral bodies through, this is coming up. I should be able to see vertebral bodies through the cardiac shadow. Now, when I look at the vertebral bodies, I'm looking right here. I can see the spinal process, and I should be able to follow all these vertebral bodies all the way down through here. Now, on my film right here, you can barely make it out, and you can kind of see you lose a little bit right through here, and you also lose a lot over here to the side. The scapula should project outside of the lung fields. When you look at the scapula, sometimes this edge right here will obscure anything else. Remember, it's part bone, it's going to have calcium. So if you don't get those bones outside of the lung field, it's going to appear a little bit more shadowed, and it'll appear like it's pathology. And so you can see the lung position or the scapular positions right here on this one and over here on this one. The way that they get an x-ray is they'll take the patient and they'll make them hug around the picture. They'll move their arms out of the way. By doing that, that moves the scapula out as much as they can. You want to make sure that scapula is out of the way. Now here you can look at it and you think, wow, it's kind of, I don't see any vertebral bodies out in here, really kind of a shaded area. I don't see any scapula over this side, not too bad through here, but it's underpenetrated, not really the greatest quality of film. Okay, so when I look at the clavicles of an x-ray, I want to make sure that they are equal distance and should be midline right here, should be parallel or mirrored to each other, and I should be able to make out the middle of it right here where they come together in the front. Very hard. That's an interesting, I don't know what that is, so maybe just overlights right there. So anyway, the clavicles should be equal, should be midline, which these are right here. If they're rotated in any way, the clavicle will appear one shorter, one longer, a little bit denser. Okay, so now have they taken a good film, and is this a good film? Let's count ribs. To count ribs, we want to have at least 9 ribs. Now, when you count ribs, you want to find number 1. The first rib looks like a C right here, okay? So looking at this one, you can see the C right here. Here it is on the left side. You find 1, work your way up here to the top to find number 2. And here is number 2, okay? So find 1, it's the C. I can make out the second one right here, but I can basically just step down. There's 2. And then 3, 4, 5, 6. See how that game's played right there? Okay. Now don't let the clavicle right here kind of obscure your image. Kind of look past it. So find 1 to find 2, 3, 4, 5, 6. Can everybody see those? Okay. Okay. I kind of let that one in just to kind of show where 1 is at. Find 2 to find 3. Let's see if we can count some on our own. This is a good film right here, even though it's hard to see. Boy, it really is a difference showing up right here versus here. How many ribs can you see first off? I'll give you a hint. Here's rib 1. Here's 2, 3, 4, 5, 6, 7, 8, 9, 10 posterior ribs. This is a good picture? Yep, pretty good one right through here. Looking at my scapula, you can see right here, they kind of come, they're midline, they're parallel. I can see vertebral bodies all through here. On my picture, I can see it through here, but here it's kind of obscured a little bit. On mine, I promise you I can see it here. Those of you who are looking at this one online, you may be able to see it a little bit better. So, is this a good quality film? Nah, you're right. No, can't even do that. Hard to even count. 1, 2, 3, 4, 5, 6, 7. I can't even make out the rest of it right there. So here I'd have a good question on, is it a good quality film? So is this a good quality film? And again, on my picture, I'm not sure why it's showing up differently on this one, but it is a good quality film. I can make out 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 ribs on this one. It's actually pretty good. On my film, I can actually see the vertebral bodies, good, adequate alignment, and there's actually pathology on this film, for those of you who can see it. If you can't see it, I'll come back to it, okay? But there is pathology on this film. Okay, now let's look at chest X-ray. First thing we're going to look at is the soft tissue in the bones. Now, if I put an X-ray up here, most people immediately go to the lungs. So we want to learn to block out the lungs, and we want to learn how to obscure everything. We want to look just at the bones. And again, we've looked at our alignment. Are all the bones in place? Is the alignment of the bones in place? The soft tissue, is it equal on both sides? And I know this is a female through the tissue that's present there. Next, we want to look at the mediastinum. That mediastinum is that area that's right here in the middle of our lungs, or in the middle of the field. So try to ignore this part, look just at the middle. Now we want to think about what structures are in the mediastinum, okay? Well, in the structures in the mediastinum, you've got the sternum. Can't really see the sternum when you're looking at a chest X-ray. You've also got the esophagus. You've also got part of the aortic arch that's right through here as well. You can also see the heart that's in the middle, and you've got the vertebral bodies right through here. The trachea kind of comes right in through here, but it actually bifurcates right underneath our clavicles right here. So if you feel your clavicles right here, you can feel that angle of Louis that's right there. The bifurcation is actually right here under that angle of Louis where it bifurcates in the right and left bronchial main stems. Whoops, back up there. Right in through here is where it bifurcates right into left. Now, again, when you look at any widening of the mediastinum, you want to think, lymphoma. It could be an aortic aneurysm. It could be a dilated esophagus, depending on how far up that widening goes. This is an example right here of an aortic aneurysm. And you can kind of see right here, you can kind of see that broadening right through there of the aneurysm, where the heart comes right through here. The aorta usually comes right here, but when you've got an aneurysm, really wide right through there. We're going to take a time out, look at the thymus. The thymus is not something that we typically see in an adult because it's usually present only in pediatrics. In fact, it's only there for a couple of hours, really, where you can see it, hours to days. But this is what the thymus looks like right here. Okay, you can kind of see the shadow of that thymus right there. The heart is actually inside of it on this day-old baby. Here's what it looks like, and you can kind of see the involution of the thymus. Here is day 1, where they're just 3 hours old. Here you can see on day 4, completely non-visible. Now it's there, you can look for it, and you could probably make it out, but you can see how that thymus really sucks down. So I tell you that so when you're looking at a newborn, you don't confuse the thymus with the heart. Okay, looking at the heart. Okay, PA view versus an AP view. This is important because it's going to make a difference on how you address the interpretation of the heart size. A PA view, this is what you typically have in your offices. Okay, they come in, you order chest X-ray, a 2-view, PA, and lateral. Well, when you do an X-ray here, you're going to have the film right here, and basically the front part of their chest is going to be close to that film, okay? Now, the heart is going to be right here towards the front, and looking right here, you can see the beams pass through and reflect and bounce off this film and come back out. And that's what's red on the X-ray. So that's what a PA view is compared to an AP view of the chest, where you've got the film right here, and then you've got the heart that's more farther out, okay? So now the heart's going to come in, or the X-ray beams come in and shine on the film back here, but it's having to go through a heart that's more in front. Now, what difference does that make? Well, here's what my hand looks like really close to the film right here. But if I exaggerate and move my hand closer to the camera, what does the heart do? It becomes larger, okay? So why is an AP versus a PA view? This is the type of view that you will see in the hospitals if they order a remote X-ray or remote chest X-ray or portable chest X-ray. It's going to have a heart view that's a little bit larger. Okay, so here's an anatomy, and this site right here, I cannot find anywhere else. That used to be one that was open to the public and to educational institutions, but it's one where you could pull it up and you could look at all the structures of the heart, the different anatomical features. You can see on a regular heart, you can see the right atrium, the left atrium, and the left ventricle, which comprises the most of the left side and the right side right through here. Can't really make out that right ventricle right through here. And you can also see other aspects of the heart. Now, here you can see just what kind of the right here is that left side, left ventricle, right atrium right through there. You always want to look at both films and appreciate right here, that right edge, the right atrium, and the left border, which is the ventricle, and the atrium right up here. Now, if this border is ever obscured, and again, this is a hard X-ray because it's being distorted up here, but you can see the edge of this one very clearly. However, over here, you cannot. If the edge of your heart or the heart border is obscured, think fluid, think buildup. It could be an infection, or it could be some type of fluid building up back into the heart, especially if you're looking down here at the sulci, but we'll get to that in a second. So always look for the heart to make sure that the borders are very clear. When you look at the lateral view, okay, looking at the posterior view, you can see the left ventricle right through here and right ventricle right up here is on that anterior border. Here's the left ventricle as well too. So again, look, these borders should be nice and clear. You also should see down this posterior view, while I've got the lateral view or the lateral view on the posterior side, look at this posterior sulcus right through here. You can see first off how clear through the vertebral bodies right here. You can see that they're clear. They will naturally get obscured up here just due to more tissue coming about. But you should be able to see the lung field right back in through here. Now, there is pathology on this one, but it's not in the lungs. This is, if I told you this is an elderly lady, walks around like this, everybody's doing the same thing. They can see that little bitty curve right there. Yeah, she's also got a little compression fractures right through there. So, okay. Now this is, if I look up here, that's a PA view, okay? This tells me, and looking at the size of the heart right through here, I can kind of understand there's a little bit of cardiac enlargement going on right here. And this is the PA view. Remember, it's going to be back closest to the film, or it's going to be up back towards the film. So this is going to be cardiomegaly, okay? Looking at the size of the heart there. Now this right here is not. This is actually an AP view, okay? What are some cues this is an AP view? Well, several cues on this one. Anyone want to be bold, be brave? Hearts, yep, it's same right here. But I can actually see the vertebral bodies very clear. Remember, that's the part closest to the film. It's going to be clear, okay? And I also got my little clips right through there. So that tells me that's an AP view, even though it's not really listed right on here. Okay, now let's look at the diaphragm. And again, forget all this up here. I want to look right through here. When I look at the diaphragm, I should see a nice, even muscle. And I want to follow this muscle all the way to the sulcus right through here. I'm really evaluating this area right above the diaphragm to see, is there any fluid buildup right there? Right through here on this side. This one's not really much fluid, even though it's not as clear as this one. This is probably just due to the density of the x-ray. But I also, if I'm ever looking at a chest x-ray for someone who's got abdominal pain or abdominal discomfort, I want to look to see, is there air underneath the diaphragm, which this person has right here. This is a perforated bowel where they have air that's escaping out into the system. So they've got air right in through here. Okay, so that's air underneath. You can see the liver, stomach area right through here, and air being trapped. Okay, now we can look at the pleura and the fissures. And remember, these are areas between the lungs, between those lobes that we have. You can kind of make out if there's any fluid buildup or any type of infectious process between the lungs. Remember, we know that the lungs are made up of lobes, 2 on the left, 3 on the right, but there's also small lobules in between that create minor fissures that may be present. You can kind of see a little bit right through there. I apologize for the x-ray on this one. Now looking at the lungs. When we look at the lungs right here, we want to look at the trachea. Should come down. We may be able to see it bifurcate right out through there, through the bifurcation. We want to look at the perihilar area right through here. And then we want to extend from the bronchi to the perihilar area. Now in here, you'll notice that it looks like there's some buildup right here, but that's actually tissue of the lungs, tissue of the cardiac right through there, and the different buildup of tissues. That's not really pathology that's present. So you got some tissue buildup right through here that makes it look like that's actually pathology. And looking right through here, it does streak down here. That's not really infectious process. When I was first starting off with x-rays, I'd look at that and think, oh boy, they've got pneumonia right there. And they'd say, no, that's not pneumonia. That's not pneumonia. Kind of that buildup that's normal, that tissue that's present right through there. And I want to look at the lung markings, and I want to make sure that the lung markings go all the way out. Now remember, it's going to be dark because it's mostly air in here. After I've counted my ribs to make sure, and here's a good one, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good lung filled up. I want to make sure a good inspiration is 9 or more. And I should be able to see lung markings all the way to the edge as I come through here. If I ever see a band right through here and it looks clearer, I may be thinking there's air, as in a pneumothorax. So when we look at the lungs, when we examine the lungs, we want to look for areas of increased or decreased density. Increase in densities will look something similar to this right here, but a lot thicker, and you can see it right there. When we have those densities, those are going to be signs of consolidation. It could be a mass. It could be some type of nodules or cancerous lesion that could be present. It could be some atelectasis that's present, or it could be an infectious process that's built up. So consider pathology. Anything that feels, especially if they say they come in, they've been coughing, they've got an acute episode. What can fill up those lungs of fluid, pus, blood, including tumor cells. Don't discount if they have just a few weeks of coughing. That few weeks of coughing may actually be an acute phase of a chronic episode, okay? An acute phase of a chronic condition. Now, when we look at it, we want to look at, is it lobar, is it diffuse, or is it multifocal that could be ill-defined? Here's what kind of a lobar ones look right here, especially if I've got a defined area right there that kind of clearly marks off. That tells me I'm dealing with something in the lobe, single lobe, okay? Looking right up here, it kind of starts to diffuse right up through here, but this is still probably part of the same lobe. If I have a lobar consideration right here versus a diffuse type of situation where I've got it over here and over here and over here and down in here, again, thinking about a perihilar type or a bat wing type of an appearance, or if I've got multifocals that could be focal area that's very ill-defined, not really in one particular area. Okay, here's that x-ray I told you there was pathology on. Anybody want to take a shot? Be bold, be brave. Looking at this right here, I'm going to chalk that. She said, don't lost my angle right through there. You're right, but that's kind of the picture on this one. Left pneumothorax, exactly right. You're thinking, wow, okay, look right here. You can kind of see I got good lung markings right in through here on the right side. But as I come on to the left side, I come up here, I can see that line right through there, and it gets a little clearer on the other side. That tells me there's air trapped in the lungs. That's more, remember, tissue is going to be a little grayer, salty, peppery. It's going to be a little clearer out through here. And you can actually see right here a difference, how grainy it looks versus how clear that rib looks. Okay. And I think I zoomed in just a little bit more to let you see it there. Okay, here's a lobar pneumonia that you can see right here. Looking at the left side as a comparison, you can kind of see it's clear all the way through, but here you can kind of see some diffuseness right through the little infiltrate that's present right there in the right upper lobe. So we're probably dealing with a right upper lobe pneumonia on this one. Okay, congestive heart failure. Here you can see on the left side an older film versus a newer film right here. So normal versus congestive heart failure. You can kind of see the curly B lines. You can see first off looking here, it's still not a great film. You can see a little bit of congestion right through here. Look at the size of the heart. It's not enlarged. I can make out the border of this one very easily compared to this one right here. I kind of make out the border. It's a little fuzzy right here, and I've lost that sulci right here on this side. I can actually see that pleural fluid right there. You can see curly lines right through there that are present on here. So that tells me, and you can see the enlarged heart on that particular side. Why is it so important to get our patients controlled, their blood pressure under control? Because if not, this is what can happen right there. So we want to get good blood pressure control now versus later. Again, normal side of the heart versus curly B lines that you can see are present right here. This can be heart failure or could be lymph carcinoma. So good history, again, is what you need to get on this one. And don't discount this. Again, assume pathology. Always assume pathology. Go looking for that, okay? If you see it, bring it up. Note your radiologist on that. See if they can help you. Okay, here's what an interstitial pneumonia will look like. Through here, you can kind of see the various, pretty much all through the tissues on both sides right here. You can see that it's really cloudy in appearance. It's not, you can see the sulci down through here, so it's not failure, fluid backing up all the way, but it is a pneumonia because, again, it goes through all the lung areas in all the lobes. Okay, masses, nodules. When I look for them, I want to look to see, is there a single nodule right here? Or are there multiple nodules that are present? Okay, is it a small nodule that's present, or is it kind of a larger nodule that's present? Again, getting your good history, depending on where you're at. Is it tuberculosis? Is it a lesion, space occupying tuberculosis, or is it a cancerous type of a lesion that could be present? There's a few x-ray sites. That Yale site I keep putting up there, but still hasn't shown up. I leave these to you to look at. Oh, good, I got a little bit. If you ever want to just practice looking at x-ray sites, I leave these for you to look at. If you want to type in radiology tutorial into any search engine, you're going to get a whole list of websites. And you can call me or text me or send an email, and I'll give you some great websites to go to in terms of walking through an x-ray. That's kind of a quick overview real quick, but I do have a few practice scenarios in terms of things that you can notice differently. Now, you won't know everything about these, but you will know that there's a little bit, you hopefully will be able to see a little bit of difference in the pathology. You can see right here, and again, I apologize, I don't know why it's not showing up as clearly on here, but you can see right here, looking at the ribs, you can count the back posterior ribs on this young person right here. They've got, it looks like appropriate ribs, but if you look at the heart, this side clearly is a lot clearer than this side over here. You can actually see the heart shifting over and that you've got some type of air accumulating on that particular side. They've actually aspirated a piece of corn on this particular one. Here, whoop, I went ahead and gave you some answers right there, but you've got a little bit of bilateral parenchymal infiltrates that are present here and on this side right through here. I've actually lost a little bit down in here, but again, notice the heart size as well that's present down in here. This is going to be a bilateral pneumonia on this particular person. Okay, this person was boating and fell onto the back of a seat, and they've got left-sided chest pain. Now, I know you're zooming in, left side right through here, but they've got chest pain. Let me see if I can actually see it on here. Yep. Boating, fell, ow, ow. Get this a lot. They boat, fall on the back of the seat, and there's actually rib fractures right in through there. So, right in through there. So I don't think I've got any more that's zooming in there. This is actually a picture of one of my colleagues' children. There's your clue right there. He actually defies the odds and plays soccer and is really active. When she kisses him and tells him great game after a game, can't tell if the salty taste is from him playing hard or the disease process. Any thoughts? Cystic fibrosis, you're exactly right. Whoop, back up, back up, back up, back up, back up. This is cystic fibrosis, and you can kind of see through the lungs right through here, he's got a lot of scarring that's present right in this parahilar, but more extending up into the upper lobes. You can see a little scarring right here. And again, this is very, she took very good care of him, able to advance. On my pictures up here, you can see a little bit more scarring that's actually right in through here. So you'll have scarring throughout the lung fields on this one. Okay. 2 lungs. Two different sets, by the way. You look right through here, you can kind of see there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 ribs, maybe right there. On this one, hard to show it on here. So there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 ribs. Look at the diaphragms is another clue. Look at the diaphragms, how peaked that is right here. You can see the sulcus right here, clear sulcus right through here. I look at the diaphragm here, it's clear, but it's flat. I also look at the lungs right here. I can see good tissues throughout the lungs. This looks darker, like there's more air trapped in this one. Diagnostics, any thoughts? COPD, exactly right. That's exactly right. More the emphysema type, you're exactly right. You can kind of see flat right here, lots of air trapping right into there. So this is what someone with COPD is going to look like compared to here. You also look at the barrel of that chest. You can see a little bit of barreling compared to this one right through there. Good job. Okay. Oh, let me give you the answer right there. What do you think this is? Well, you can kind of see that you've got some small cell and you've got a large mass right in through here in that left middle lung right here, and you got some small tumors that are present right in through there. So you can kind of see some history of this young lady or older lady on this one. Very common trap, very common. Now I can speak and show this slide up here. You all know who this person is right there. No? Oh, how many of y'all know who that person is, right? Thank you. Okay. Validation. So you need to look at Dana-Carvey, SNL, church lady. So that's a very common one. Yeah, don't forget, use your system on this one. Use a good systematic approach to come in and look at your x-rays. And again, it's easy just to go straight to the lungs right here instead of remembering your steps. So remember, make sure that's lined up. You've got good angles. Your clavicles are lined up appropriately. You can count your ribs. You can actually see it right here. 1 to 2 to 3, 4, 5, 6, 7, 8, 9. You've got good lung, heart margins right through here. Mediastinum's not wide. Looking at the bones, well, you can tell something's not right there. Looking at the bones on this side, comparison, looking at the soft tissue right there. Make sure you continue your process on that. No idea. If I can give you some pearls, 2 pearls that I can tell you. One is about how the U.S. Department of Treasury goes to look for forgeries. How do they train people who go through and find counterfeit bills? Well, I always was scared of this position. How do they teach them to find all these little problems? Well, because counterfeiting requires, involves so many differences, the way they teach people to learn how to find counterfeit money is to teach them and help them memorize normals. They learn what the normals are, and they seek the normals, they study the normals. And then when that abnormality pops out, it stands out to them like a sore thumb, so to speak. So if you can learn to find x-rays, look at x-rays, even normal x-rays, learn to appreciate x-rays, go to your hospital, talk to the radiologist, look at x-rays, let them point out pearls to you. Learn to value what is normal. And when you look for the abnormals, and when abnormals present to you, they stand out very easily. My final one right here, 2-year-old child playing with older sibs reportedly swallows a coin that they are playing with. Okay, well, they take in, get an x-ray, and when somebody comes in to my x-ray or my office and says that they swallowed something, I think, oh my goodness, please don't be in the lungs, okay? Well, you can look right here, and I'm relieved that it's not in the lungs, because if it was in the lungs, I think quarter, dime, all it's got to do is turn like that, and I'm blocking off an airway, okay? So I think, whew, it's not in the lungs. Yay for that one, okay? Go team. And so I see right down here, I say, well, the good thing is that coin's not in the lungs. The bad thing is that ain't a coin. That's a lithium battery. Now, if I were to assume that was a coin, and if I would have just looked at it and said, ah, well, it's a coin, it's fine, you're okay, I would have misdiagnosed that one. Because that's a battery, I've got to return that one. And I'm sorry that it's not standing out too well on this one, as much as it shows here. But that's a referral that's got to be surgically taken out. So again, assume pathology. Don't assume normals. Always seek to find the things that are wrong, okay? If you seek pathology, you're more likely to find it than if you assume normals, okay? Thank you very much. I will take any questions if there are any. Okay, y'all are wonderful. I will pass the buck.